We recently spoke about cardiomyopathies, and now we're going to talk about other forms of myocardial disease. There's going to be just a little bit of overlap between this particular lecture and the prior lectures on cardiomyopathy. First, we're going to start out with a case, a 4-month-old female golden retriever who had an episode of collapse or seizure. It also has had a cough for 3 days that was suspected to be due to infectious tracheobronchitis. And the referring veterinarian started some antibiotics, but there was no help. The dog had been previously vaccinated, had never been on heartworm preventative, and the owner was worried because the dog next door was diagnosed with heartworm yesterday. Of course, based on what you know about the heartworm life cycle, that should not be a contributor to any current disease. So here's our dog who had a 2 out of 6 systolic murmur at the left apex. A cardiac gallop was noted, as well as an arrhythmia. Arterial pulses were weak, and the dog was tachypnic with fine crackles in the hilar region. Mucous membranes were pink to pale pink with a capillary refill time of 2 seconds. On the electrocardiogram, there was sinus rhythm with evidence of left ventricular enlargement, ST segment changes, and ventricular premature depolarizations originating from the left ventricle. Only one radiographic view was obtained before the dog got short of breath, and there is some cardiac enlargement, perhaps a little bit of left atrial enlargement, maybe a little bit of perihilar interstitial pattern, but there's also a little bit of a cranioventral pattern in front of the heart. So the radiographs maybe show some cardiac enlargement, but the findings are not classic, and indeed the pattern in front of the heart could be compatible with a component of pneumonia. On echo, all 4 chambers were dilated. The left ventricular wall and interventricular septum appeared to be thin relative to the size of the left ventricular cavity. There was reduced left ventricular systolic function, 1+ mitral regurgitation that was directed centrally, and a thrombus was noted in the left ventricular cavity. So what's the ECG diagnosis? Ventricular premature depolarization with left heart enlargement pattern. The radiographic findings show cardiac enlargement perhaps compatible with mild pulmonary edema and maybe a component of pneumonia. So the radiographic findings are a little confusing. Does the dog have congestive heart failure? I think that maybe it does on the basis of the entire picture, but it may not be clear that the cough is entirely due to heart failure. The echocardiographic findings are compatible with dilated cardiomyopathy, but dilated cardiomyopathy is most commonly seen in middle-aged or older dogs. It's much less common in a young dog like this. We'd probably think about treating the dog with furosemide, ACE inhibitor, pimobendan, and probably an antithrombotic given the thrombus in the left ventricle. That also is very unusual in a dog. Dogs rarely get thrombus inside the left atrium or left ventricle with heart disease, whereas cats often do that. And what prognosis would we offer the owner? This seems very concerning in a young dog, and after discussion with the owner about the possible options, they elected to put the dog to sleep. And on necropsy, there was dilation of all 4 cardiac chambers with pulmonary edema, small volume pleural effusion, as well as small volume ascites. There was a large thrombus in the left ventricle, as well as myocardial and renal infarction, probably as a result of the thrombus in the ventricle. There was an inflammatory response in the myocardium indicative of myocarditis, and inclusion bodies were seen suggestive of parvovirus as the cause for myocarditis. Again, here's an inclusion body that is inside of the ventricle right there. So that last case was an example of myocarditis, and again, the findings can overlap with the other forms of heart disease we've talked about. That particular case looked a lot like dilated cardiomyopathy, except for the age of the dog and the thrombus in the left heart. So myocarditis can be a result of viral disease, bacterial infection, fungal or parasitic disease, or it can be immune mediated in origin. Myocarditis can be identified as an inflammatory response in the myocardium, and common clinical manifestations of myocarditis can include congestive heart failure, cardiac arrhythmias such as atrial or ventricular arrhythmias or atrioventricular conduction disturbances, and thromboembolic disease. Probably more often than not, the heart is a relative bystander in cases of myocarditis. The heart doesn't really jump out as the main organ system that's affected. Other organ systems may dominate the clinical picture, and then if the animal does not make it and a necropsy is done, you might identify myocarditis on the necropsy. So parvovirus myocarditis was perhaps first described in the late 1970s, where puppies 3 to 8 weeks of age died quickly with something that looked like cardiomyopathy. And we see less of that picture now, probably because many of the dogs carry antibodies against parvovirus. Currently, when we see it, it tends to be in dogs 2 to 4 months of age or a little bit older, and they present with evidence of heart failure. There may be evidence of myocardial necrosis or lymphocytic inflammation on histopathology, and I think often the parvovirus as a cause for something that looks like dilated cardiomyopathy in a young animal is postulated more often than it's proven. So viral myocarditis happens frequently in people. There are literally hundreds of viruses that can lead to a myocarditis. In veterinary medicine, a number of viruses have been identified: foot and mouth disease, as well as blue tongue virus in sheep, encephalomyocarditis virus in pigs, primates, and mice, equine viral arteritis. In cats, we recognize that feline infectious peritonitis virus, a form of coronavirus, can cause an inflammatory change in the myocardium, especially a arterial inflammatory response. And FIV in cats has been described to be associated with a myocarditis as well. Here's a picture of an arterial blood vessel that has a dramatic inflammatory response in the wall. So this would be a vasculitity associated with feline infectious peritonitis that resulted in a myocardial problem. We also see Borrelia create a problem with conduction through the atrioventricular node. The Lyme organism has a predilection to concentrate in the AV nodal tissue and can cause either cardiomyopathy appearance or more often just a problem with advanced AV block, as is seen in this particular case. Let's talk about another case. Here's Finnegan, a 5-month-old male Labrador cross who had decreased energy and abdominal distension for about 5 days. He'd been owned by new owners for about a month, and he was rescued from Texas. 2 of his littermates and the dam died of unknown causes. He was identified to have hepatomegaly and abdominal distension, and some blood work was done which identified increased liver enzymes as well as a markedly increased NT-proBNP. The dog had previously had diarrhea and hookworms, was treated with parental pamoate, and it was up to date on vaccines and flea, tick, and heartworm prevention. The owners had been feeding the dog a grain-free diet, and it also had been feeding a grain-free diet before it was adopted. Laboratory testing, the normal values in blue, or the values within the normal range in blue, and in red are the abnormal values. So the dog had a moderate anemia, hypoalbuminemia, elevated phosphorus, mild elevation of ALT and AST, as well as a markedly elevated NT-proBNP with normal values less than 900. Dog also had a lymphocytosis. And of these, we might say that perhaps the phosphorus could have been elevated as part of being a young growing puppy still. And sometimes puppies have a slightly lower hematocrit than normal, but this is fairly low hematocrit. On physical exam, the mucous membranes were pale. Body condition score was 4 out of 9 with moderate muscle loss over the back. The heart rate was very fast at 300 per minute with mild tachypnea and mild dyspnea noted. The dog had arrhythmia with pulse deficits. A 1 out of 6 systolic murmur was noted on the left side of the chest over the cardiac apex, but there was no cardiac gallop appreciated. The jugular vein was distended about halfway up the neck. Arterial pulses were a little bit weaker than normal and characterized as fair, and the dog had abdominal distension. Radiographs were obtained and demonstrated cardiomegaly and probably a little bit of an increased interstitial pattern in the perihilar region, as well as marked hepatomegaly and loss of detail in the abdomen. The electrocardiogram was difficult to interpret. It was originally thought that perhaps the dog had a ventricular arrhythmia, but after watching for a period of time, it was identified that there actually were P waves present and that those were related to the QRS complexes and that there were bursts of a rapid tachycardia and that the sinus beats had a deep S wave. And the eventual assessment was that the dog had a wide complex supraventricular tachycardia with right bundle branch block morphology. On echo, the left ventricle was dilated with reduced contractile function. The right ventricle was markedly dilated, and the wall of the right ventricle was subjective slightly thinned. There was a little bit of mitral and tricuspid regurgitation and mild to moderate left atrial enlargement with moderate to marked right atrial enlargement. So Finnegan seemed to have a dilated cardiomyopathy phenotype with the right heart affected a little bit more than the left heart. The dog is young for typical dilated cardiomyopathy, which usually occurs in middle-aged or older dogs. There was some chance that this could be a diet-related form of dilated cardiomyopathy, either related to taurine deficiency or grain-free diet. And a taurine level was submitted, and that came back as normal. The other possibility is tachycardia-induced cardiomyopathy, and that begs the question, was the supraventricular tachycardia a cause for the current cardiac disease, or was it a sequela of atrial enlargement? And myocarditis is also a possibility, and the dog did originate from Texas, so we considered pathogens that might be identified there. The dog had congestive heart failure, more right-sided heart failure than left-sided heart failure, supraventricular tachycardia with abnormal conduction through the heart. And the original plan was to start with pimobendan, diuretics, amiodarone, and taurine supplementation pending taurine levels. We also submitted another test, submitted a Chagas disease test, and that came back as clearly elevated. And we thought that there's a pretty good chance that the dog had Chagas cardiomyopathy. And then itraconazole was added into the therapy, and it seems that some dogs might respond favorably to the combination of amiodarone with itraconazole. So trypanosomiasis, Trypanosoma cruzi, is the causative agent in this, and it's transmitted via a reduvidae bug or a kissing bug. It's seen predominantly in Texas, Mexico, and South and Central America, although it also is seen in some other states of the southern United States. It can lead to an impressive myocarditis, and the right atrium and ventricle may predominate. You can see either left-sided or right-sided congestive heart failure, and possible treatment options are listed there, but neither of those might reverse the cardiac changes once those are seen. So another example of myocarditis. And other protozoal myocarditis might include toxoplasmosis, which is one of the potential forms of myocarditis that's been proposed in cats. In most cases, other systems tend to predominate with toxoplasmosis, the GI tract or the eyes or the central nervous system. But cardiac lesions can develop as a necrotizing myocarditis. Overt clinical disease is much less common. And Leishmania has also been identified to create a lymphoplasmacytic myocarditis with myocardial necrosis and granulomas. Certain parasitic diseases may insist in the myocardium, trichinella spiralis, echinococcus, and potentially strongylosis in the horse. And there are a variety of non-infectious acquired myocardial disease that we should have some familiarity with. Some of them are suspected to be heritable. There are nutritional deficiencies, myocardial toxic agents. We see cardiac changes as a result of physical injury or shock, and myocardial disease can be noted in certain systemic disease processes. An example of a presumed hereditary problem is a hereditary cardiomyopathy in Syrian hamsters, and there are a variety of other rodent models that have been created to develop cardiac disease or systemic hypertension. Other suspected heritable causes include glycogen storage diseases, Duchenne's muscular dystrophy, which has been seen in both cats and golden retrievers, a hereditary cardiomyopathy in turkeys. Hypertrophic cardiomyopathy in some cats is presumed to have a genetic basis, and dilated cardiomyopathy in dogs likely also has a genetic basis, at least in some breeds. And dilated cardiomyopathy in cats also appears to have a genetic underpinning to it. Selenium and vitamin E deficiency can lead to a form of myocardial disease, white muscle disease. And a variety of other nutritional imbalances can cause myocardial disease, including one we've already talked about previously, which is taurine deficiency in cats. It's also been identified that selenium overdose given by injection can cause a cardiotoxicity in horses. One of the ones we see in a small animal hospital with some frequency is Doxorubicin cardiotoxicity, which creates a dilated cardiomyopathy-like syndrome that can result in either arrhythmias or congestive heart failure. This seems to be at least in part due to oxidant injury in the myocardium, and the higher the dose, the more likely we are to see that. A cumulative dose of greater than 240 milligram per meter squared is more likely to result in a cardiotoxicity in dogs. Cats seem to be less sensitive and may require closer to 400 milligram per meter squared in order to get into trouble. We do advise some caution in use of doxorubicin in breeds of dogs predisposed to dilated cardiomyopathy, as sometimes the toxicity is seen at doses as low as 100 milligram per meter squared. And if cardiomyopathy with congestive heart failure develops, it often has a very poor response to treatment with survival times less than 2 months. Another thing that can happen is catecholamine cardiotoxicity. So this particular heart is opened up and you can see hemorrhages, especially in the subendocardial region of the heart and in the myocardium. And these hemorrhages can be in part related to catecholamine cardiotoxicity. It's recognized that you can create myocardial damage and a cardiomyopathy-like syndrome in animals if you infuse high doses of certain catecholamines for prolonged periods of time. These hemorrhages in this particular heart were part of a cardiopulmonary resuscitation case where multiple doses of epinephrine were given in addition to chest compressions and defibrillation, which also could cause problems with the heart. There are many additional cardiotoxicities reported, including certain drugs that are cardiotoxic to certain species. Blister beetle toxicity can cause myocardial lesions in horses, and monensin can also cause a significant myocardial toxicity in horses. Certain systemic disease can cause change in the heart. So renal failure is associated with cardiac disease, and there's sort of an interplay between the heart and the kidneys in certain older animals. Renal failure can lead to systemic hypertension, which might cause left ventricular hypertrophy or arrhythmias. Can also lead to myocardial necrosis, and a uremic pericarditis is also described in veterinary species. Systemic hypertension also affects the heart, and there are actually 4 organs that could be considered target end organ damage in animals with systemic hypertension. In the heart, we get left ventricular hypertrophy, and sometimes the proximal aorta becomes enlarged. The eyes, we can see retinal hemorrhage and retinal detachment. The kidneys, high blood pressure can lead to glomerulosclerosis and progressive renal failure. And in the brain, we can see hypertensive encephalopathy or central nervous system stroke or hemorrhage. And here's some examples of changes that can happen with systemic hypertension. We have retinal detachment here, as well as on the bottom panel here with a little retinal hemorrhage. Left ventricular hypertrophy in the upper right panel, and mild cardiomegaly with a tortuous aorta in the lower left panel on the thoracic radiograph. Adrenal masses can also result in cardiac changes. Cushing's disease can lead to systemic hypertension, and pheochromocytoma can cause pulsatile release of epinephrine and norepinephrine, and this can lead to tachycardia or other cardiac arrhythmias, systemic hypertension, collapse. And these signs tend to be episodic whenever the tumor releases catecholamines into circulation. It's also recognized that certain central nervous system lesions, tumors, sometimes diseases in the neck can lead to cardiac arrhythmias or areas of myocardial necrosis. This syndrome of the central nervous system leading to changes in the heart has sometimes been termed the brain-heart syndrome. Here's again that same heart as before, as a reminder that defibrillation and other electrical injury can damage the heart. So multiple efforts to try and defibrillate the heart can lead to myocardial necrosis or subendocardial hemorrhage. Dogs with systemic disease can get ventricular arrhythmias, and this can be particularly problematic. Some of these arrhythmias are bad enough to require treatment, and some of them are less concerning. The potential clinical associations in dogs are probably just about anything that can lead to shock or coagulopathy. So motor vehicle accidents, dogs who have gastric dilatation and volvulus, dogs with a splenic mass, sepsis, pancreatitis, immune-mediated hemolytic anemia, or immune-mediated thrombocytopenia, and a variety of other diseases can get ventricular arrhythmias that sometimes require therapy. These ventricular arrhythmias are sometimes associated with small areas of myocardial damage or myocardial necrosis. And again, they're common in dogs with any form of shock, but I think they tend to be more common in dogs who are more than 2 or 3 years of age and who are large breed. Ventricular arrhythmias can also be seen in horses with certain acute abdominal diseases and strangulating or inflammatory lesions. Diabetes mellitus has a close association between diabetes and the development of heart disease or heart failure in people. The association is less clear-cut and probably a little more limited in veterinary species. But cardiac disease is recognized in both dogs and cats with diabetes mellitus, and congestive heart failure is possible. And I think we see many more cats who have diabetes mellitus who eventually get a form of cardiomyopathy than dogs. Hyperthyroidism clearly has significant implications for the heart in any species that gets hyperthyroidism. The dogs can get hyperthyroid associated with a thyroid carcinoma, but the thyroid carcinomas in dogs are less likely to be functional. They're less likely to be associated with hyperthyroidism. They are often very vascular. They are more likely to invade the trachea, which makes them then difficult to resect. and they are also more likely to metastasize than what we see in cats. Cats often get an adenoma, but the adenoma tends to be functional, creating a hyperthyroid state with tachycardia, as well as cardiac arrhythmias, sometimes systemic hypertension, and less commonly congestive heart failure. Severe hypothyroidism also has the potential to affect the heart, either via arrhythmias or reduced contractile function. In dogs who have severe hypothyroidism, maybe in those especially with myxedema coma or very high cholesterol levels, may end up with atherosclerotic changes in the heart. So you may be able in these coronary arteries to see little white plaques in there, which is atherosclerotic lesions in the coronaries. They also can be seen in the cerebral vessels as well, where they might lead to myocardial infarction or CNS stroke, respectively. And another adrenal disease would be hyperaldosteronism, an aldosterone secreting tumor of the adrenal gland, which can lead to systemic hypertension, left ventricular hypertrophy, and a variety of electrolyte changes. We also can see the myocardium affected by certain infiltrated diseases. Amyloid is possible, although less common in veterinary species than in people. We occasionally see infiltration of the myocardium with lymphoma or eosinophilic disease, as is present here in this cat that had feline hypereosinophilic syndrome, and a variety of other disease processes that infiltrate or affect the myocardium are possible. So that's a large number of disease processes, and it's hard to keep all of those in mind. I think there's probably a few main take-home points from this lecture. One, myocarditis happens in many veterinary species, and it can be either infectious or immune-mediated in origin. Animals with myocarditis might develop congestive heart failure, and it can look like dilated cardiomyopathy, although sometimes in cats it looks more like hypertrophic cardiomyopathy. Arrhythmias are common, especially supraventricular arrhythmias, ventricular arrhythmias, and AV block. Sometimes we'll see thromboembolic disease, and it's possible that other body systems may dominate the picture and that the heart is not a significant player in the clinical picture. Probably another main take-home point is there are a variety of toxins, deficiency, or systemic diseases that affect the heart. And that a few to keep in mind might be chemotherapeutic agents, including Doxorubicin, systemic hypertension as a result of kidney disease or adrenal gland disease, and trauma, sepsis, or systemic diseases like splenic mass or gastric dilatation and volvulus, especially are likely to cause cardiac arrhythmias.